So the frontline Hodgkin lymphoma data is fascinating. I mean, it's my favourite area, really, Hodgkin lymphoma. And, we've had ABVD and we've had escalated BEACOPP for a long time. Then we had ECHELON-1 that sought to incorporate Brentuximab Vedotin, the antibody-drug conjugate against CD30, with AVD, so-called A+AVD, because it's Adcetris is the trade name. And we saw a progression-free survival advantage there, but we did not see an overall survival advantage. And the sort of progression-free survival rate probably wasn't as high as the more intensive escalated BEACOPP treatment. So although it did secure a license in Europe for stage 4 classical Hodgkin lymphoma, it's never gone through NICE. So in England, we can't use it, it's not reimbursed. And I think in fairness, we probably weren't that disappointed because for our higher risk patients, we were quite happy to use escalated BEACOPP. However, what we have seen is an overall survival advantage developed now with the ECHELON-1 trial, which I have to say was a surprise to me, but I think it's real. I mean, it's only a press release that we've seen so far, I should say. We've not seen the data yet presented, and I think what we all want to see is what were those deaths? What was it all Hodgkin deaths where the difference lies, or were there any toxicity deaths? Because we don't actually use 6 ABVDs as a standard of care now, so there has to be some questions about what those deaths actually were. But that's very, very interesting. And I think for me in my practice, where I would like to use A²VD, assuming that this overall survival benefit does look real and relevant, is for those older patients, perhaps 45, 50, 55, 60, where I wouldn't want to use escalated BEACOPP because it's just too intensive and the treatment-related mortality is too high. But I would instead be using an ABVD-AVD approach. Well, then sure, I would want to use A²VD because it's associated with a higher overall survival. I should say the toxicity, there is a slight toxicity difference between A²VD and ABVD, definitely more peripheral neuropathy with A²VD, and there was a higher febrile neutropenia rate, so we do need to use primary GCSF prophylaxis. So I think it's, again, we don't quite know if we're going to be able to use it in England. Will the company now take this through NICE for that indication of stage 4 classical Hodgkin lymphoma? My personal view is I hope they do, because I think there is perhaps a small but important role for it.